Welcome, everyone, to Healthy Minds, Bright Futures: How to Navigate Mental Health and Build Support. This is the podcast where we discuss how clinicians can best work with educators and families to meet children's mental health needs and give them the strong start they need to be successful in school and in life. Today, our topic is autism spectrum disorder, or ASD. According to the latest CDC data, ASD occurs in 1 out of 31 8-year-olds, but that statistic hides extensive variations. For example, that rate is 1 in 103 children in Texas, yet it's 1 in 19 children in California. ASD is, of course, a spectrum, but the diagnosis process can be less standardized than it is for many other conditions. And getting children the support they need can be a challenge for clinicians and special educators anywhere, which is why today we're going to discuss screening, co-occurring conditions, and how to work with children and families to give kids the support they need to be healthy and happy. I'm joined today by Dr. Craig Zinkiewicz, a licensed school psychologist who specializes in working with children with autism, ADHD, and learning disabilities. He practices in Arizona, where he works with preschool and school-age kids, including adolescents. And we're going to dive into some best practices. Dr. Z, thank you so much for joining me today. It's okay if I call you Dr. Z, right?
That's absolutely fine. That's what most people call me. So I'm impressed by the pronunciation of my last name. So kudos, win already.
It's my job, Gotta be if I can't do that.
Fair enough. Fair enough.
So, to start us off, let's talk about the variance that we see in rates of ASD. So, not only, do we know they vary a lot between states, but these rates are also going up just in general. And we hear a lot about how this increase is driven by greater awareness of autism. But then we see these big variations. So, why do you think we see growth yet variability at the same time?
Yeah, I love this question. This is like table talk for me, so this is more fun. You got to peer into my household, but fair enough. So yeah, great question. Loves the idea of increased social awareness. That's obviously a part of it. It just seems like such a simple, broad answer, right? And we could say that for a lot of things. So we're more aware, and then conversation over, we're good to go. And so that's where, I like the critical thinking, the nuance, and pretty much this entire time we're going to talk is all going to be about nuance. And so, like, when I hear that stat, not necessarily the state specific stat yet, but just the stat in general, like autism diagnosis has increased probably fivefold in the 20 years, maybe even more than that at this point. And so it's just a national thing. And so you have to think of like, oh, what's up? And social awareness doesn't cut the mustard, at least in that case. So then I started thinking of like, who who is getting diagnosed? Where is this increase in diagnosis coming from? Well, who are these people? And it's less likely it's our more severe kiddos. So the kiddos who would be typically diagnosed at a level 3. Now, just to clarify, right? Autism has different levels of diagnosis, at least after. It's more of a severity rating, maybe more of a current functioning rating. Think of it like how adaptive the kid is, or the adult is in certain cases. And level 1 being more minimum, needing requiring some support, where level 3 requiring a lot of support. So if we just use some logic here, the study that you're referencing doesn't mention this, but my guess is that that increase is not at the level 3 area, right? We know those kiddos. Those kids are getting identified. They're the ones who are nonverbal, having some severe behaviors. They're getting identified young. It's the level 1s that are probably leading to the rise and increase, right? The kiddos who they're quirky, they have communication skills, but maybe they're awkward and they have some sensory need and some attention difficulties. And so those are the ones that are coming to schools and clinics, and parents are like, what's going on? Is they're a little different than what I'm used to. What's Please evaluate. And so we're talking about these fringe, like the fringe of the ASD spectrum, right? That one side. And so then it's like, all right, well, if we're talking about those kids, why is it increased? And so there's probably a lot of reasons for that, but I think most of it, which is what the little world that I come from, which is more of diagnosis and evaluating, is that as you get to the fringe, you still have the same diagnostic criteria. That diagnostic criteria is very loosey goosey. It's kind of general and vague, and it's broadened over years, right? As within each iteration of the DSM. that comes out, it broadens, and so now you're capturing more kids. And the way I look at it is like today SD diagnosis is like reaching out and grabbing other characteristics of other diagnoses that are around it in the DSM, like attention problems from ADHD, rituals and compulsions from OCD, and they're pulling it all in, and now it's just capturing a lot. And so it's kind of easy if you just apply the criteria in that general sense to every kiddo you see. Someone's going to have a little bit of that stuff.
Yeah, that's really fascinating to like be widening out a diagnosis in that fashion, and it would follow if more symptoms or more behaviors would fall under this umbrella, then naturally those numbers would go up, especially on that fringe, like you said. So really getting to the bottom of this is actually pretty complex.
Well, yeah, it's we're not gonna solve it today in our 30 minutes, but I think, like,
We're not gonna solve it on one podcast?
that'd be great, hey, maybe we'll pull something together, but I like, it's more just thinking about it, right, and putting some kinda light on it, like, just how they could have face value. It's not necessarily a bad thing that it's increased, but I think some trepidation as to and some investigation as to why might is definitely necessary, so I appreciate it. They're the statewide reason's interesting. That's really fun because that if it's that wide from a Texas to California, and it's other states too in between, there's got to be something that's specific to that state. Now, it's not just more awareness, right? The social, I'll leave it here with the social side. There, our society has kind of changed a little bit, even in the 12, 15 years I practiced, where like there is less stigma around diagnosis in general. I see more families seeking it out and less with less trepidation about getting diagnosis. More like, hey, we want to figure out what's going on, as opposed to like the nothing's wrong with my child, right? It's more the opposites now. So I get more kids coming to my door. Uh, and then there's the more political side where I think there are some incentives in certain states for diagnoses, right? Either funding or scholarships and things like that. And autism's usually the big ticket item.
And that's why we wanted to talk about this today. It's because this is such a multifaceted condition, and there are all of these both medical and physical and even political implications. So we will narrow it down for our audience a little bit, and we'll focus a little bit more on some of those more medical and screening processes. We'll move to that.
I'm good with that.
So if we think about, school psychs like yourself, how can clinicians, let's say this is very broad, but improve screening processes in schools so maybe we could get to something that is a little more standardized?
Sure. Right. So you're already answering that my solution as to like what you would have to do because I can only control my little world of the
Right.
evaluation. I can't control who comes to the door, but I could at least have my practice be as consistent as possible. Right. So you're right. So I think the idea is you need better standardized practice for evaluating for autism. I'm not in charge of changing the diagnostic criteria. That's a governing body that does it on its own. So without that, I just got to know how to apply that. And so you're right. We need to find a standard of practice for evaluating. And that's not just schools. I do both. I dip my toes into both worlds. I work in the schools and I work in private practice, and both have the same problem, right? Where like there's screening and there's evaluating, right? So if you ask specifically about screening, our schools are equipped academically very well typically for screeners. Usually there's benchmarks. There's beginning of the year benchmarks, middle of the year benchmarks, end of year benchmarks. And so we know we can catch kids who are struggling with reading along the way, right? Even those aren't perfect, but I think that's the best the best where we're at. There's even some districts that are awesome with some more social emotional type screeners, right? They're more broad, that kind of screen for more anxiety, depression based symptoms. Like if you really wanted to catch my kiddos on that fringe with autism, or maybe those who just have those symptomology, I would want to more focus on like the social. the social part of screening, right? So a screener that would ask more questions about how are they interacting with peers, how are they doing in group work, what when they're on the playground, are they with anybody? Can they initiate conversation? Is it all about is the talk just about what they like, right? And they can't have a back and forth. There's all these kind of screening type questions that if we added that to like the normal, just a teacher observation, a parent observation in the beginning, middle, end of year each year. Take a 1 minute kind of deal. You might be able to catch some more kiddos who have some concerns and plug in some intervention um, before maybe even sidestepping some of the diagnosis need.
Yeah. Yeah, no, I think the idea of making these types of screenings, even not necessarily if they need an evaluation like you had said, but just to treat these social skills a little bit more like the way we screen for academics is a very powerful shift in thinking. And you noted that ASD and these other, that these social and behavioral issues that they are complex. We're talking about that fringe. So let's kind of talk about some overlapping conditions that contribute to that level of complexity, let's say that, comorbidities or co-occurrences. What do clinicians like yourself need to know with how all of these things come together?
Yeah, this is the hardest part of the job. This has been kind of like my what keeps me up at night when I'm evaluating, right? Where I'm like toiling between multiple diagnoses. And then the key is that there's no check for this. There's no blood test after to be like, oh, I nailed it. I'm right. And so right. And sometimes the difference between the diagnosis, which we'll talk about specific ones, will change your what you're recommending for treatment. And so if it's autism, you might go a more applied behavioral analysis, social pragmatic language route. Whereas if it's like an OCD, which has been the last like 5 evals for me, where OCD, obsessive compulsive disorder, is is already diagnosed and parents are wanting to know if their kiddo also has autism or does have autism. And so that's a whole different treatment methodology, right? So if you're calling it wrong, right? And wrong is in quotations here for the for the listeners. You're calling it wrong. You're pushing them in the wrong direction. And so like I mentioned OCD, like that's been the one most recently, but there's more common ones. ADHD is co-occurring, right? That's common, commonly also diagnosed. There's tons of other like symptoms of other anxiety disorders and things like that that kind of blend in and meld into autism. Intellectual disabilities, like mild ones, can have the same social problems, even sensory problems, right? And so, like, if you go for it, like, just with a line item, like checklist down the diagnostic criteria, you're not gonna get anywhere. You're gonna be like, oh, they meet for all of those. So either you diagnose 5 things and then send parents into a mad scramble. You kind of have to like read in between the lines of the nuance of the presentation, right? And if you want, I can give you an example, like to it if you want to indulge me. But
Yeah, no, please do. Yes, I think our listeners would definitely appreciate it.
fair enough, right? So I've been battling with OCD, and I guess not personally. I guess maybe my wife would say I've been battling with OCD personally, but well, that's a side note. The differential diagnosis between like a diagnosis of obsessive compulsive disorder and autism, and the kiddos are coming in. They have tons of rituals, right, that are repetitive in nature, right? Whether it's twisting a specific like toy, walking around the house pacing and talking to it, or they have to have their pillow in the right exact way, and their mom has to tuck them in it and say the exact prayer, right, that they need to hear at the end of it, whatever it may be. There's these repetitive behaviors. Socially, they're struggling because they're not making friends. They can't. They're afraid to go out into large groups, right? There's some sensory need. And so if you look at both criteria, like, all right, well, we got it. But the nuance is that, right, like autism, OCD is more of an anxiety driven response. Like there's a fear, some kind of irrational fear that leads to those repetitive behaviors. Whereas autism, those repetitive behaviors, those same exact ones, it could be the exact same behavior, is more of a self-soothing, stimming, right? So a self-stimulating behavior. And so it's not coming from a place of fear or stress or worry, but from a place of I just feels good, right? I need to do this to feel good. And the only way you're gonna you can't just observe it. And interviewing, like parent may not see that. The only way you can really know is by kind of interviewing and spending time with that kiddo or client. And that's time isn't always on our side, right? When we're looking for intervention. So it's really difficult to get that right.
Yeah, I think that's a really powerful example of how the same physical action, could have and can have, like, a different reasoning behind it. Something different is driving it, but just the outward presentation of that symptom, say, is the same. So really digging into what the cause is. Yeah, I mean, this is obviously very challenging.
Guess what? A kiddo could have both, right? It's nothing saying they couldn't have both. So it's not just a matter of teasing between the two, right? So it's really, it takes time, care, right? Like, you have to really interview. It's not, you can't over rely on your tests, although they help. You can't over rely.
Yeah, yeah, no, absolutely. And that segues nicely into I my next question, which is again, focus on what these clinicians in schools can do. So in the school setting that you work in, or is part of what you are working in, is it about having like a more robust screening process to kind of get to the core of these things, or to really just put together an IEP?
Yeah, so the evaluation process needs to be robust, in my opinion, right? That's part of the problem, is that evaluation processes, if you were just to poll everybody, they're probably everyone's doing something different, right?
Yeah, and having the time, as you mentioned, the time to do all those.
I think school psychs, this is not to put down my private practice, my brethren, but school psychs have a unique opportunity to kind of really dive in, because you have access to the kiddo way longer, right? So like in private practice, I have my parents, they sign up with me, we come in for an intake, then I see the kid maybe 1 full day, 2 full days, and then with our tests, and then we're done. It's not like a three week, several month thing. I'm always seeing them in the clinic. When I'm in school, right, or school psychs, you get to see the kiddo on the playgrounds, at lunch, interacting with peers. You can observe anytime you'd like. You could spread your evaluation. Most timelines are over months, not days. And so you can spread the evaluation out over time to really kind of tease apart those symptoms. So school psychs are really unique, but the evaluation itself needs to be robust. Like, I'm not a fan of just, hey, let me just listen and then diagnose, right? That is possible. You could go to a doctor and do that tomorrow. I think you should really be doing a combination of, like, normative kind of rating forms, like get at, is this behavior different than others their age, right? That's a key. And then also, I want to see the direct version, direct assessment. Let me test that skill. I want to see that skill and how that compares to others their age, and that combined could help me with my diagnosis or eligibility for schools.
My next question is about exactly that, which is, what are some of the tools that clinicians and school psychs can use to do this? And especially with you having experience in both the like clinical and school setting, obviously let's level set, and I'm sure that our audience realizes this, but it- a medical diagnosis does not take place in a school. And we are not suggesting that it should, obviously. So when we're talking about school psychs, what are some of these assessments or screening tools that you have had success with or experience with?
Yeah, fair enough. And ironically, they're not. The tools are not that different across schools versus private practice. They're pretty much the same. And so, in general, right, most school psychs and most psychs will use rating forms, right, to start us off. So there's more broadband ones, like the BASC, right, behavior assessment of children, right. That's amazing. And that gets at like lots of different behaviors, but you're going to hone in, if it's autism, on the social skill adaptive rating. You're going to hone in on the atypicality ratings, because if those are elevated, that's kind of pointing me in a direction. Then you can narrow it down to with more specific rating forms that ask about autism symptomology, like the autism spectrum rating scale, the ASRS, or social skills, right? That's broad. I like to narrow that further. So the social responsiveness scale, second edition of the SRS2, that all that stuff helps me get perspective, right? Like, hey, what are parents seeing? What are teachers seeing? And is it significant, right? Every 8-year-old's got some quirky stuff, got some they make some social faux pas, and they're not meant to be perfect. I honestly not even just 8-year-olds. I'm making tons of those probably right now in this interview.
But certainly not 8-year-olds and certainly not 4-year-olds, because I know that's our other, having had kids at both of those ages, yeah, they can all do some interesting things.
Exactly. You can't. That's why we can't just go with the anecdote. I can't just interview Rose and be like, "Hey, has your kiddo had some difficulty with back and forth conversation?" You're gonna be like, "Well, they're 4. Of course they did." And then so I want to know, how is their conversation skills relative to other 4-year-olds? And so you start with that perspective. And that just gives me an idea of, yeah, we are seeing something. Everyone's seeing something that's out of the norm. And then you can go and start testing those skills, and that those tests start to help you figure out, like, all right, um, what skills do they have, right? Can they have that back and forth conversation? Is it just the nonverbal part of things like reading faces or reading cues? The sensory part of things, is there a sensory profile that helps me? Are they more sensitive? Or are they more have low registration where they're not really aware of their surroundings? All that stuff gets on the nuance of the kid that then you can use to not only diagnose but hopefully help like write a plan that's specific to that child. And that would be where the IEP comes in, or whatever plan you write.
Absolutely. No, I think that makes a lot of sense. And, I love the fact that we are addressing nuance as much as we are, because I think we would be remiss if we did not. Because talking about ASD, this is a complex condition. So to help tease that out, let's talk about the other aspect of a child's life and where to get that fuller picture and to get that nuance. And that's caregivers, that's families, not the school setting. So how do you as a clinician best collaborate with them?
Any evaluation, we'll talk from evaluation standpoint, and I could talk from like just throughout the whole process, even
Yeah, yeah,
after
yeah.
diagnosis. But from evaluation standpoint, whether you're in a school or clinic, you're going to involve parent and caregiver. You have to, actually, because it's a neurodevelopmental disorder, right? So meaning that it exists in early development. I mean, you better be asking parents, what were you seeing at this age? And maybe you need to have targeted questions and be as specific as possible, because it's not everyone speaks the psych jargon that we speak, right? So you have to be able to ask it in a way where you can kind of attach to it. But yeah, I need parents to kind of fill me in on what was happening, and that helps with that early development side of things. Autism doesn't show up when you're 25. It's been there all the whole time. You just have to kind of know where to look. And so I need them just from a collaborative, from a interview standpoint. I need to know what the kiddo's been. But then, like, the reality is that post diagnosis or even eligibility in schools, the school will take care of their side of things, but they're focused on education, right? Getting the kiddo to access the curriculum and progress through the grades. um, it's you really need a wraparound service, meaning you probably need some support outside of school, whether that be uh, speech therapy for pragmatic language like social language, or an occupational therapist outside of school to help work with more of the sensory regulation and or dysregulation in that case, or maybe someone to help with more of the adaptive side of things, like getting prepared to live on your own or go to college. And I need to know, how do I what do I do when I have to go to the grocery store, when I do my own laundry, right? I love those kind of those are the fun ones for me because I love prepping my kiddos for that. Um, but you need parents to be involved in that side of things. The school can only take on so much, and so it's a matter of just having conversations, just connecting them with the right resources. Not just being like, here, call this place, but maybe being like, hey, I called them first. I spoke to the provider. This is who I think will help you. Here's a warm handshake handoff, right? Of, this is the person I want you to talk to. And you need parents on board with that.
I love that. Yeah, a warm handshake handoff. That's great.
Sure, there's a better term for it, but that's the one I came up with in this moment. So we'll go with it.
Works for me.
There you go. Thank you, Rose.
I think it's really important to keep that emphasis on the benefits for the child, and for their in all of those different aspects of life, not just academic success as it is narrowly defined. Things like being able to go to the grocery store and stuff like that. So let's kind of keep broadening things back out. In light of everything that we've discussed, what do you think is the biggest challenge that clinicians are facing in addressing ASD?
Yeah, and we definitely touched on it, but and I can't break it apart into more because they're just one, but it's two things that are connected. Too broad of diagnostic criteria mixed with no standardization of practice, right? No standardization of evaluating for these conditions. The idea that we're not going to have too much onus or responsibility for changing the diagnostic criteria, but I would hope that anyone who's listening, right, who has any kind of say in that, right, would have some more critical thinking when it comes to diagnostic criteria for not just autism, for a lot of other disability categories. Until there's a day that we can pinpoint a gene or something specific, we need to make sure that we're diagnosing appropriately, and so make the criteria look more specific to what autism is. And I have a reason for that. And then on the evaluation side, I would prescribe more of a robust evaluative practice like I described here, where there's a combination of a really in-depth interviewing with stakeholders, parents, where there's a combination of just a more indirect assessment, like rating forms that give you a normative perspective, and then direct assessment of all those skills that actually extends over time, not just a one-stop, come on in my office, I saw you for 8 hours. Even that's probably pretty good compared to what's out there. But I want it longer, right? And so having some kind of standard of care for that would be my solution. And people will disagree, but that's my take.
Hey, it seems like having a good standard of care seems. I feel like that's a pretty decent answer.
I appreciate it. Yeah, it sounds logical to me. Who would have
Right?
thought, right?
Yeah. You only do this every day.
Yeah.
So if we were to look, let's say we look back, into the past, we may take a look and think that, some of our processes and our methods, that those seem outdated now. Isn't that just sort of the nature of medicine and of science that we are just continually trying to get better?
That's well said, right? So, like, I never look back and be like, "Wow, they were horrible. That was why were they doing that? That was horrible." Because like that's what you had, and then I would be ignorant. I know that if you were to ask, we're gonna fast forward in the future, 20, 50, maybe more years, and we're like, what that Dr. Z guy was talking about nonsense. A direct assessment, rating forms? No, we do a blood test and we're good to go, right? So like you just have to know we're practicing in our time. Don't be paralyzed, right, by that we don't have the perfect answer, because that could be a case where clinicians are like, if we don't have an answer, what am I doing? Right. And so you got to use what you got. But have a reason, like be as comprehensive as possible to some extent. So that way, at least you could sleep at night with, hey, I did everything I could to kind of peel apart those diagnostic criteria. And that's important, right? The idea that even though we can't be proven right or wrong, the intervention after that follows does change and matter based on what you say. And so you don't want to push someone in the wrong direction if you just because you did a less than comprehensive evaluation.
Yeah, yeah, absolutely. Well, I think that we're about at the end of our time here, and I think that is a that's a great way to wrap things up. Doing the best you can with what you have and as comprehensive as possible.
I think that's great. Yeah, that's it. Well said. Better summarized than me.
Well, Dr. Z, thank you so much for your time today and for these insights. This is obviously I don't have to tell you an important issue for schools, for families, and this has been so much good information for our audience. So thank you so much.
Rose, it's been a pleasure. I love talking about this stuff. So thank you.
Great. Absolutely. And thank you as well to our listeners. And we hope that you learned some strategies that you can take back to your school or your practice. And if you'd like to learn more about supporting children with ASD, visit pearsonassessments.com/autism. And I'll say that again. That first part is all one word, pearsonassessments.com/autism. And at that site, you can dig into more detail about assessments like the BASC that Dr. Z mentioned, and other tools that can help you address the well-being of the whole child. Thank you so much for listening, and we hope you'll join us again soon on our next episode of Healthy Minds, Bright Futures.